In 2003, there was a consensus workshop sponsored by the European Society of Human Reproduction and Endocrinology and the American Society of Reproductive Medicine in Rotterdam. And out of this came this criteria for diagnosis of PCOS. So there are 3 criteria, and you need to have 2 out of the 3 criteria fulfilled for the diagnosis of PCOS to happen. It is very important to know that the diagnosis of PCOS is a clinical diagnosis. That means it's not something that we would diagnose just looking at an ultrasound or that we would diagnose just looking at blood work. You'd really require the entire picture and taking a history from the patient in order to make a diagnosis. So what are the 3 criteria? Hi, superhumans. I'm Dr. Mavis Garcia.
And I'm Dr. Wise.
We're 2 of the physician leaders at Markham Fertility Center, otherwise known as our baby, MFC.
As fertility specialists, we've witnessed firsthand the challenges, triumphs, and the myriad of emotions that come with trying to conceive. Whether you're just starting to think about having a baby, actively trying, or facing challenges along the way, My Fertility Podcast will be your go-to resource for honest conversations and a supportive community.
So grab a cup of coffee or tea and settle in, and let's demystify the world of fertility together.
Today's episode is on PCOS, or polycystic ovarian syndrome. And this was a topic that had a huge response on Instagram. And a lot of people wanted us to cover this topic. And once we started going through it, there was so much stuff about PCOS that we wanted to talk about. We've actually split it into 2 episodes. So today we've got part 1 of our journey into PCOS.
And we have to admit, even for us fertility specialists, this is a complicated topic. There's so many nuances to it. So we are going to do our best to simplify it for you and let us know how you like it.
PCOS, or polycystic ovarian syndrome, or also sometimes called PCOS, I've heard that one too. It's a chronic hormonal disorder that can have an effect on so many aspects of someone's health. And it very often goes undiagnosed, despite the fact that it can have so many effects and changes on someone's life. It's also very misunderstood, which is wild to me, actually, because it's so common, and yet it is misunderstood both by physicians and by patients. And that in and of itself can lead to lots of significant physical and emotional challenges for those that are affected by PCOS. And hopefully this is going to help a lot of people today.
PCOS is one of the most common endocrine disorders in women worldwide. It actually starts during adolescence and it can fluctuate over a lifetime. It can vary in terms of prevalence on the population, but anywhere between 4 to 18% of people with ovaries in the population can experience PCOS. At its very core, it's basically a hormonal imbalance that disrupts the cyclical function of the ovaries. And if you want to remember about the cyclical function of the ovaries, you should check out episode 2 where we talk about the menstrual cycle.
First, we're going to talk about some of the signs and symptoms of PCOS. It's really important to note that PCOS presents differently in every person. And so not all women who have PCOS will have all of the symptoms. And the symptoms, as we said, can fluctuate over the course of someone's life. Probably the most common symptom of PCOS is someone who has irregular or even absent menstrual periods or menstrual cycles. That means an irregular cycle is going to be a cycle that's maybe less than 21 days. And again, when we're talking about cycles, we're talking about from the first day of full flow of the period to the next first day of full flow of the period. So less than 21 days or even more than 31 days. Again, it's important to note that cycle patterns can fluctuate a lot throughout someone's life. And for patients with PCOS and for patients even without PCOS, sometimes cycles are going to be more regular, and sometimes there might not be any menses at all. Why is this happening, right? Why is this important? Well, if ovulation does not occur, the ovaries do not produce progesterone, and the lining of the uterus can become thicker, and it just kind of grows and grows and grows and becomes unstable. And so it can shed irregularly, which can result in sometimes heavy and or prolonged bleeding and spotting. And so that's why we will also often see patients with PCOS with irregular cycles may have really heavy periods or prolonged periods where they're having bleeding for 7 days, 10 days, 14 days, 3 weeks, or even just kind of ongoing vaginal spotting as well.
Another symptom of PCOS can be the presence of acne or excessive hair growth. Now, excessive hair growth is very much related to a patient's ethnicity and family history. The hair growth seen in PCOS is usually black and very coarse. You can also notice that there is a male pattern of hair growth, like baldness in the front of the head. You can see excessive hair in the upper lips, in the shins, the neck, and the sideburns, as well as the chest and the abdomen. It is normal to have hair in these areas. Not all hair in the shins is associated with the disease, but certainly we see that in PCOS, women tend to have a little more hair growth in these areas than otherwise.
Obviously, hair growth is a really sensitive and touchy subject sometimes for women, right? I mean, especially nowadays where the hairless look is very trendy. But, the way that I
Go laser.
Yes, no, I love laser. Though my only res not doing it sooner. But what I will say is the way that I address this or the way that I talk about this is, do you have more hair growth on chin, upper arms, upper legs, sideburns than other women in your family? Right? So I'm trying to normalize it based on somebody's family history, somebody's ethnicity, because we know that there's huge variation for that. So that's how I kind of try and address that question. I have to admit, I've never pulled out the Ferriman-Galway scoring system to assess for excess hair growth. I mean, I think I memorized it for the exam, and then I will admit I promptly forgot, but that's the textbook way of assessing it.
Yeah, the Ferriman-Galway score is just basically a visual chart that gives a score, and based on that, you can have an objective way of assessing hair growth. But you're right, I've never used it either.
PCOS sometimes will also present with increased weight, and is typically thought of as increased weight, especially around the abdomen or sort of central obesity. That being said, up to 30% of women who have PCOS may maintain a normal weight before and after the diagnosis, so it's not universal.
Everything that we've talked about so far are some of the symptoms that you might experience if you're having PCOS. Now, let's talk about the actual diagnostic criteria for PCOS. In 2003, there was a consensus workshop sponsored by the European Society of Human Reproduction and Endocrinology and the American Society of Reproductive Medicine in Rotterdam. And out of this came the criteria for diagnosis of PCOS. So there are 3 criteria, and you need to have 2 out of the 3 criteria fulfilled for the diagnosis of PCOS to happen. It is very important to know that the diagnosis of PCOS is a clinical diagnosis. That means it's not something that we would diagnose just looking at an ultrasound or that we would diagnose just looking at blood work. You'd really require the entire picture and taking a history from the patient in order to make a diagnosis. So what are the 3 criteria? Number 1 is irregular cycles. That looks like cycles that are more than 35 days apart or having less than 8 menstrual cycles in a year.
Another important criteria is excess androgens, either symptoms of this or blood work evidence. Androgens are a family of hormones. They're a group of hormones, which testosterone is one of them. And so androgens we typically think of as hormones that are related to testosterone that bring on symptoms that we typically associate with male features. That could be things like acne. That could be things like hirsutism or that excess hair growth we talked about. It also can be thinning hair, especially in the crown of the head while you're sort of retaining your hairline in that typical male pattern baldness picture. Now, again, you can have symptoms of it or blood work evidence of these excess androgens. Both of them would meet the criteria for this particular point when we're looking at the diagnosis of PCOS.
The 3rd criteria is polycystic looking ovaries on ultrasound. There is a specific look to ovaries on ultrasound. Usually polycystic ovaries has more than 20 follicles in a single ovary or a volume that is bigger than 10 cc's. There is a specific appearance of the follicles on the ovaries, and that is called the string of pearls. It's very important to know that this polycystic ovarian look on ultrasound can be present in about 25% of healthy women with regular cycles and without any androgen excess that do not have PCOS. So it can also be considered a variant of normal. It's also very important to understand that the ability to see an ovary on ultrasound and the experience of the person doing the ultrasound and interpreting the ultrasound also has a role in determining whether the ovaries appear polycystic looking or not.
Why are we seeing these polycystic looking ovaries? What are they? This really is an example of something called follicular arrest. In a normal fertile female, and again, we talked about this in our menstrual cycle episode 2, check it out, it's really good. A single follicle will mature and it undergoes ovulation from a pool of these antral follicles, or I call them baby follicles or baby eggs, that are present in the ovary since the birth of that person. In PCOS, what happens is that the follicles will grow up until a point and then they stop growing, where you don't get that dominant follicle that grows and becomes the big one and gets ovulated out. They're just sort of in this line where they stop growing. You literally see them in a line, or this like string of pearls appearance on the ultrasound. It's this follicular arrest that we're seeing when we're looking for these polycystic appearing ovaries on ultrasound. It's also really important to note right now that AMH is not part of the diagnosis. So checking an anti-Müllerian hormone level is not part of the diagnostic criteria right now. That being said, I suspect probably maybe in the next iteration or newer iterations of diagnostic criteria, AMH will likely get included, because we do know that women who have PCOS generally have very high AMH levels, but it's actually not part of the diagnosis right now.
Another important aspect to the diagnosis of PCOS is to recognize that it's also a diagnosis of exclusion. What this means is that there are other conditions that can mimic PCOS. There could be things associated with elevated prolactin, thyroid dysfunction, another condition called non-classical congenital adrenal hyperplasia or Cushing syndrome. So all of these things need to be ruled out before we can say that the irregular cycles and the hirsutism are associated with PCOS.
We got to talk about this right now, okay? This has to be one of my big pet peeves when it comes to the world of fertility, especially PCOS, because I really, 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 really dislike the name polycystic ovarian syndrome. I think it's really misleading, and I think it leads to a lot of stress and anxiety and adds to the confusion of something that's already really confusing.
That name does causes a lot of grief for our patients. You're right.
Okay, so these so-called cysts on the ovaries of polycystic ovarian syndrome are not really cysts in the way that we think about them. These are baby eggs or baby follicles, right? And so when we're looking on an ultrasound, follicle may look the same as a cyst in the sense that you see this fluid-filled sac on ultrasound, but it's a really, really important distinction to make. Because when we think about cysts and ovarian cysts, we think about doing surgery to remove the cysts as a way to fix things, or we think about the risk of cancer and then potentially being ovarian cancer as well. I get that question a lot. People ask me, okay, can I surgically remove these cysts and then to fix my polycystic ovaries? It totally logically makes sense and I totally get it. But the key thing is that these are not cysts. These are baby eggs. These are these little primordial follicles or antral follicles, and we don't want to remove them, because if we do that, we're going to actually really significantly impact your egg reserve or your egg number. We see these follicles in a normal menstrual cycle, they will start growing and they will start cycling, but that they are in this stage of arrest in PCOS, and that's why we see them. Please, please, please keep in mind, PCOS is not the same as ovarian cysts. They're two different things, really. Yes, I will still call it PCOS, but I do it begrudgingly.
There's another name for PCOS, which is worse. Yeah, the
Stein-Leventhal syndrome. Yeah, okay, that's fair. That makes it sound more serious.
PCOS is a lot easier to pronounce.
Yeah, it's easier to spell too.
Easier to spell.
Acronyms I can spell. I got into med school not with my spelling abilities, guys.
But you're right. You're right that it is really a misnomer and it causes a lot of grief. So hopefully this will clarify that. Now that we have talked about what is PCOS, we've talked about why we hate the name, we've talked about some of the symptoms associated with PCOS, and we also have talked about the diagnostic criteria of PCOS, we want to talk about the cause. Why do some women have PCOS? What's actually going on at a physiological or a molecular level? Well, the answer is nobody really knows. really the answer to this question. There's a lot of
Doesn't it
theories.
feel like the answer to a lot of questions when it comes to fertility?
Pretty much,
Yeah.
yes. There is a lot of controversy. There's a lot of papers published on it, but the very clear pathway of PCOS is not very well understood. We know that genetics plays a huge role because it is seen in families, although we haven't been able to identify a particular gene associated with PCOS. There is some theories about some exposures in uterus that might predispose women to PCOS, although that also hasn't been very clearly understood. There have been some theories about endocrine disruptors associated with the pathophysiology of PCOS. Endocrine disruptors are defined as chemicals that can interfere with the endocrine system by mimicking hormones such as estrogen. At a molecular level, we know that PCOS is related to insulin resistance, and that can be some of the reasons that we see increased weight in PCOS, although we're going to talk later about another subset of PCOS that is not associated with weight gain at all.
PCOS can have a number of other health issues and associated conditions and other health implications because of this insulin resistance and because of this hormonal disturbance. For instance, one of the big ones, of course, is type 2 diabetes. We know that people who have PCOS are at higher risk of developing type 2 diabetes. When I see a patient who has irregular cycles and I'm suspecting PCOS, I will often check a hemoglobin A1C level or check a blood sugar level so that we can see whether that's going on as well. PCOS is also associated with obesity. Not every patient with PCOS is going to be obese, but we know that there's a much higher risk, that about 80% of patients with PCOS are going to be at a higher weight, either overweight or obese. Along those lines, we also see higher rates of obstructive sleep apnea in patients with PCOS. Obstructive sleep apnea, or OSA, is a condition where there's a more soft tissue in the upper airways. And when somebody lies down and when they're asleep and all those tissues relax, it can actually compress the airway and can cause brief spells where the breathing stops, otherwise known as apnea, while you're sleeping. And this can be very disruptive to somebody's sleep, and it can be quite dangerous also for the strain on the heart. It's important to note that people with sleep apnea may not know that they're doing this. They may not know that they're obstructing and may not know that they're having these periods where they're stopping breathing. Sometimes if they're sleeping next to somebody, that somebody might recognize that they are snoring, or that they might even recognize they have periods where they're waking up and gasping as if they had stopped breathing or as if they were holding their breath. And so that's why sometimes I'll talk to patients about organizing a sleep study to check this out. PCOS can also have higher rates of heart disease, as well associated along with obesity and the sleep apnea. Now, for sure, in our world, we see patients with infertility with PCOS, and we're going to talk a lot about that in part 2 of this PCOS series and how we manage infertility. And that's often due to the ovulation dysfunction and these irregular ovulations that are unpredictable and that are more spaced out. Another big thing that we see in the world of gynecology is higher rates of endometrial cancer. This is really important. The lining of the uterus is called the endometrium. And when a person has a period or a regular menstrual cycle that's about 28 days, the lining gets shed and regenerated every 28 days. And so it's always constantly being changed out, if you will. I don't know if you ever heard this analogy, but I remember in medical school, the way that they taught us was that estrogen was like the fertilizer.
Yes.
And progesterone is like your lawnmower
Yes.
or your hedge trimmer, if you will. And when we're thinking about the lining of the uterus. For patients with PCOS, they will have these longer periods of higher levels of estrogen exposure without progesterone, because again, they have not ovulated, so they don't get that corpus luteum, they don't get that progesterone production. The lining of the uterus gets exposed to more estrogen for longer periods of time, and that's like your fertilizer for your lawn. So it grows. Without that progesterone, without that lawnmower to kind of keep it neat and tidy, it can start becoming overgrown with weeds, meaning it can start becoming irregular. And over time, like we're talking, 10, 20 years, it can become precancerous or even cancerous. And that's why we know that there's much higher rates of endometrial cancer. That's cancer of the lining of the uterus in patients with PCOS. When a patient has PCOS or has very irregular cycles and they've not had a period in a significant amount of time, and they're over the age of 35, then I will often talk to them about potentially doing a biopsy of the lining of the uterus just to make sure that the lining is still nice and healthy and there's no concerns there.
Speaking of the endometrium, everybody don't forget to check out episode 11, where Dr. Shan goes into detail about the role of the endometrium in fertility. I had to interrupt there because that was such a great episode. But we're still talking about health conditions associated with PCOS. And I think it's important to understand how PCOS can impact the health of a potential pregnancy. Women who have PCOS and conceive, whether they conceive naturally, which can happen in PCOS, or whether they conceive with the use of assisted reproductive technology, there are definitely increased risks in pregnancy in women that have PCOS. Some of these risks are increase of gestational diabetes, which is why it's very important for women with PCOS to be screened for gestational diabetes early in pregnancy and then again mid through the pregnancy. There's also increased risk of high blood pressure in pregnancy and preeclampsia. Women with PCOS might also have slightly elevated risk of miscarriage, and this is related to the hormonal imbalance. They could be increased risk of weight gain during pregnancy. Ideally, we want to look at about 25 pounds of weight gain throughout the pregnancy. And if you have PCOS and gestational diabetes, sometimes excessive weight gain can happen as well. In addition, there is increased risk of intrauterine growth restriction and preterm delivery, and this may have to do with placenta issues associated with gestational diabetes and high blood pressure. And there is also increased risk of requiring cesarean delivery, not so much related to PCOS itself, but because of the risk of gestational diabetes and the risk of having an elevated BMI if you had an increased weight prior to getting pregnant and then you had more weight gain during pregnancy related to the metabolic disturbance associated with PCOS. Now, having PCOS doesn't mean you're automatically going to have any of these problems. It doesn't mean that you have to be considered high risk, but it's important to be aware so that we can do early screening and minimize any of the risk associated with polycystic ovarian syndrome. In reality, most of my patients with polycystic ovarian syndrome do really well, specifically because we're aware of this risk and we can do early intervention and early monitoring.
We've talked a lot about PCOS and weight, and I think there is a perception that people with PCOS are all overweight or obese because it focuses in a lot on weight, but that's simply not the case. And we know that there is lean PCOS, and that's somebody who has PCOS, meaning they can meet 2 of the 3 of the Rotterdam criteria, but have a normal BMI, meaning it's under 25. And it's important to note that the symptoms and signs are actually really similar for lean PCOS patients as for other PCOS patients. And about 20% of patients with PCOS will have lean PCOS. The diagnosis, though, is they're more likely to be misdiagnosed, however, because, again, I think still a lot of people associate PCOS as somebody who's higher weight. We know in patients with lean PCOS, they have similar prevalence of something called acanthosis nigricans, which is like a darkening or a velvety darkening of the skin in certain skin creases. They can also have the same menstrual dysfunctions, those irregular menstrual cycles. They can also have the hirsutism and develop the endometrial hyperplasia, which is that precursor to endometrial cancer that we spoke about. Their hormonal profiles can also be very similar, meaning that the blood work results in somebody with lean PCOS and somebody who's overweight or obese with PCOS can be quite similar in terms of those levels of those androgens that we talked about. And they have similar rates of insulin resistance and type 2 diabetes. It is thought that, though, that patients who are obese with PCOS, their insulin resistance or their blood sugar issues might be a bit more severe than patients who have lean PCOS. There was a study that was published in 2009 by Majumder et al. That showed that there is a greater prevalence of type 2 diabetes and impaired glucose tolerance and this endometrial precancer, endometrial hyperplasia, in obese cohort patients with PCOS, and that they are at a greater risk of these things at a younger age than patients who have PCOS but who are lean, who have that normal BMI. That being said, I think that there's not a lot of research out there in the world specifically about lean PCOS, so it's not as well understood, but I think it's really important to point out that not everybody with PCOS is going to be overweight or obese. And it's also important to point out that although we talk about weight a lot when it comes to PCOS, patients with lean PCOS, we don't tell them to lose weight. That's number one really important thing. We're just aiming for a healthy BMI for all of our patients.
Yeah, this goes back to PCOS being poorly understood because it really boggles my mind that two women can have the same diagnosis, PCOS. On a physiological level, they can have very similar profiles. They both have insulin resistance, they both have hyperandrogenism, yet the phenotype is so different, and nobody really understands what is happening at a molecular level between lean PCOS and obese PCOS and why the same condition is being expressed so differently in different types of people.
Let's talk about some common questions when it comes to PCOS. I was doing some research for this episode and I was Googling away about PCOS and all the things that we've talked about. Google has a fun feature now where we'll give you some commonly asked questions that people have asked about. So I'm going to throw these out to you and we'll see if you're as good as Google, Dr. Garcia.
All right, me versus Google. Let's go.
All right. So first question, PCOS and menopause. We've talked so much about fertility and all this, but what happens to people once they enter menopause if they have PCOS?
There is not a lot of research on this, actually. We do know as you enter menopause, well, if you had irregular cycles, now you're going to have no cycles because that is the definition of menopause. And that has nothing to do with PCOS. That's just menopause and what it is. Whether or not the same metabolic abnormalities that a person had in the reproductive years continue after menopause is not very clear. My understanding is that they do. So if you had insulin resistance prior to menopause due to PCOS, you might continue to have insulin resistance in menopause. If you had hirsutism in premenopause due to PCOS, you might continue to have that in menopause, even though now you're not going to be having high AMH level, although it's not part of the criteria. You're not going to be having loss of follicles present in the ovaries because in menopause, the ovaries don't have all of those eggs and all of the follicles, but some of the metabolic and physiological abnormalities are still present in menopause.
Here's another common question from Google. How do I cure my PCOS?
Well, there is no cure for PCOS, and I'm using question marks, although you can't really see me. And what I mean by that is there's no pill that we can give you before you have PCOS and now you don't have PCOS. However, there are many management options for PCOS depending on your goals. Part 2, we're going to go into management and treatment of PCOS. So I'm going to be brief here to say that there is no specific cure, but there are many, many, many management options for PCOS.
Here's another one. Does PCOS ever go away?
Well, PCOS waxes and wanes. Throughout the whole reproductive cycle, it's very common for women to say, you know, when I was 16, my periods were very irregular and I have all of these issues. And then I was on the birth control pill for a while. And then I came off the birth control pill and I had this nice period of a year. My cycles were regular, were perfect, and everything was fine. And now I'm back to having the PCOS symptoms again. So it can wax and wane. It doesn't necessarily disappear for good, but we do know that if women are having excessive weight and they lose weight, then that can make the symptoms of PCOS less severe. So it might feel like PCOS has gone away, although it doesn't really go away for sure, but it can wax and wane throughout your reproductive lifespan.
Here's another question that I actually never even really thought about or even really talked to my patients about, but I'm going to mention it from now. What's the difference between PCOD versus PCOS?
Polycystic ovarian disease, which is PCOD, versus polycystic ovarian syndrome, which is PCOS. It's the same thing. Some people call it PCOS as well as opposed to PCOS, but they're all describing the same phenomenon. There's really no big difference in the medical literature.
Dr. Garcia, I think you're smarter than Google.
Really? Well, I did go to medical school and residency and fellowship, and I don't think Google did all of that.
So what, you're telling me that a doctor might actually do better than Dr. Google?
Say it louder for the people in the back.
I couldn't help myself.
Have you seen those mocks? What is it? Don't confuse my medical degree with Google or something like that.
Yeah. Oh, I want a sticker for that just to put on my forehead sometimes. Yeah. But no, thank you very much for putting up with my questions.
Anything for you.
I think we've talked a lot about some of the aspects of PCOS. Still lots more to talk about, and we totally get that. And we're going to talk more about PCOS and management, PCOS treatment, PCOS and fertility and infertility in part 2 of our PCOS series.
If you're having any of the symptoms, if you have any concerns about PCOS, please see a physician. If you're specifically concerned about reproduction and PCOS and your ability to conceive, please see a fertility specialist. There are many options available for people with PCOS.
I know a really good fertility clinic.
Market Fertility Center, of course.
Oh, right, yeah. And that's a wrap for today, Superhumans.
If you're looking to connect, get social with us. Follow us on YouTube and Instagram at My Fertility Podcast or visit us online at markandfertility.com. And don't forget, follow, subscribe, and share your favorite episode.
Thanks for listening to My Fertility Podcast and for being a vital part of our community. We know you've got this.
We're signing off until next Tuesday.
If you found this episode of My Fertility Podcast helpful, please take a moment to head over to the review section and leave us your thoughts. Your reviews and comments are incredibly valuable to us and help guide future episodes. We also welcome you to direct your questions to info@myfertilitypodcast.com.
My Fertility Podcast is produced by Rabbit Media Inc. in conjunction with Dr. Garcia and Dr. Weiss. Music from Mix Kit Raising Me Higher by Ajay Stelino. My Fertility Podcast is not intended to replace any type or variation thereof professional medical, health, or legal advice, nor should the content be taken as medical advice. Please contact your primary healthcare professional regarding any medical questions you may have. The information presented in this podcast is based on the knowledge and understanding of the host at the time of recording. Medical knowledge is constantly evolving, and new research may change the understanding of health-related topics. While we strive to provide accurate and up-to-date information, we do not guarantee the completeness, accuracy, or timeliness of the content. The views expressed in this podcast by guests are not those of the host or the management. This podcast is not intended to impose any type of discrimination. My Fertility Podcast and its management are not responsible for any losses, damages, or liabilities that may arise from the use of this podcast.